my channel. Let's start studying our next topic, which is the Foleys catheter. So what are the indications of the Foleys catheter? They are the short-term catheterization and the long-term catheterization. Short-term includes the post-surgery and in the critically ill patient to monitor the urine output and the prevention of the urethral obstruction from the blood clots with the continuous or the intermittent bladder irrigation and the installations of the medications into the bladder, and surgical procedures involving the pelvic or the abdominal surgery, repair of the bladder, urethral and the surrounding structures, and the urinary obstructions, for example enlarged prostate and acute urinary retention. Long-term catheterization includes the urinary incontinence that is not being improved by the medicines, and the refractory bladder outlet obstructions and the neurogenic bladder with the urinary retention, and the prolonged and the chronic urinary retention, and to promote the healing of the perineal ulcers where the urine may cause the further skin breakdown. The third is the intermittent catheterization. It is done when there is a collection of the sterile urine sample is required, or provide the relief of the discomfort from the bladder distensions and the decompressions of the bladder, and measure the residual urine. It is also used for the management of the patient with the spinal cord injury, neuromuscular degenerations, and the incompetent bladders. The catheters, they can be made up of the rubber, plastic, PVC, or the silicone. Silicone catheters, they causes the trauma while insertions and also cause the less irritability. There are these are preferred in the patients with the long-term catheterizations more than 28 days, and the sizes of the Foley's catheters are in the farad and the millimeter. The different sizes are the 5 farad, 6 farad, 8, 10, 12, 14, 18, 20, 22, 24, and 26. The types of the catheters. The catheters, they are the two-way and the three-way. In routine, the two-way catheter is used. A three-way catheter is used for the irrigation and the drainage. Further classification, they can be done in as the indwelling catheter and the external catheter and the short-term catheter. Indwelling catheter, the urethral and the suprapubic catheter. An indwelling catheter is a catheter that resides in the bladder, and it may also be known as a Foley's catheter. This type can be useful for the short and the long period of the time. The external catheter includes the condom catheter. A condom catheter is a catheter which is placed outside the body. It is typically necessary for the men and who do not have the urinary retention problems but have the serious functional or the mental disabilities such as the dementia. A device that looks like a condom and covers the penis head, a tube leading from the condom device to drainage the bag. The short-term catheter. A person may only need a catheter for a short period of the time after the surgery until the bladder empties. After the bladder empties, it's necessary to remove the short-term catheter. What are the requirements? It is a Foley's catheter, urine bag, 20 cc disposable syringe, xylocaine gel, sterile gloves, solution for the cleaning the skin, and the sterile water and the cotton swabs. The color, the orange and red, they are the 6 and 8 French size. 1 FR is equal to 3 FR is equal to 1 mm. For example, if there's a 12 FR catheter is 4 mm in the diameter. The yellow is for 10, white is for 12, green is for 14, orange is for 16, red 18, yellow 20, purple 22, blue 24, and black is 26. The black has the biggest bore. So procedure: if a patient is conscious, counsel the patient, explain the whole procedure and seek the consent. If the patient is not conscious, explain the whole procedure to the patient guardians or the close relatives and seek the consent. Ensure the privacy. The patient, the legs, they should be spread and their feet, they should be together. Lying in a supine position relaxes the bladder and the urethra and facilitating the easier catheter insertion. A tense urethra compresses the catheter, which results in the resistance during the insertion, causing the pain and sometimes even the damage to the underlying tissue of the urethra. In severe cases, this may cause the bleeding. Assist the patient in getting into the supine position if necessary. Put the sterile gloves on. In the case of the catheter insertion, the sterile gloves, they helps ensures that the bacteria are not introduced into the urethra and that the patient's body's fluid do not come into contact. Scrub the patient's gentle area with the disinfect and soak closed cotton swabs and rinse or scrub the area with the sterile water or the alcohol to remove any debris. Repeat any as needed. When the finish, lay down the surgical drapes around the genitals. Leave the space for the access to the penis or the vagina. For female patients, be sure to clean the labia and the urethral meatus, the urethral opening on the penis, and cleaning they should be done from the inside to the outside, so or not to get contaminate the urethra. In other words, start a urethral opening and gentle work your your on outward in a circular fashion. This is known as the no touch technique. The catheter that comes in a sealed sterile kit, and before opening the kit, ensure you have the correct catheter for your purpose. You will need the catheter that is the correct size for your patient. Coat the distal portion of the catheter 2 to 5 centimeter portion of at the tip with the generous amount of the lubricant, for example, the xylocaine gel. This is the end you will insert into the urethral opening. Be sure to lubricate the balloons portions at the tip as well. If the patient is female, hold the labial open and insert the catheter into the urethral meatus. Hold the catheter in your dominant hand, and your non-dominant hand to spread the patient's labia so that you are able to see the urethral opening. Generally insert the tip of the catheter into the urethra. If the patient is a male, hold the penis and insert the catheter in the urethral opening. Insert the tip of the catheter into the patient's urethra with your dominant hand and continue pushing until the catheter sits in the bladder. The length of the catheter they should be generally fed through the urethra or into the bladder until the urine is observed. After the urine began to flow, the continue to push the catheter into the bladder another 2 inches to make sure the catheter is against the neck of the bladder. Stop if you feel any resistance, for example, large prostate or the stretcher, and inflate the balloon with the sterile water. Use a water-filled syringe to inflate the balloon by the sterile tubing connected to the catheter. The inflated balloon they serves as an anchor as not displace the catheter when moving. Once inflated, pull generally on the catheter to ensure the balloon is sealed snugly against the neck of the bladder. The amount of the sterile water used to inflate the balloon depends on the size of the balloon on the catheter. Using usually about 10 cc of the water is required, but checking the size of your balloon to be sure. Use sterile water only, not saline, because the saline they may crystallize and make the removal of the catheter difficult. If you need to take the sample of the urine for examination, take it. Connect the catheter to the drainage bag. Make sure you place the drainage bag lower than the patient's bladder. Catheter they works by the gravity. Urine cannot drain uphill. Don't place the drain bag alongside the patient on the bed. Neither should be in the lying on the floor. When the bag fills with the urine, it usually become heavy and it will pull the catheter and stretches the urethra, thus causing the pain. Hang the pain through the hole by the side of the bed. In a medical environment, catheter they can be left in for about as long as 12 weeks before being changed. Therefore, though they are often removed much earlier, some catheter they such as the straight or the intermittent catheter, for instance, are removed immediately after the urine stops flowing. In a medical environment, the catheter they can be left for a long as the 12 weeks before being changed through. They are often removed much earlier. Such some catheters, such as a straight or the intermittent catheter, for instance, are removed immediately after the urine stops flowing. Contraindications. Catheter is contraindicated in the case of the urethral trauma in the treatment of the urge incontinence. The taking the catheter out. If the catheter had been more than 3 days in the bladder, clamp the bladder intermittently for 1 day before taking the catheter out. Due to this, the tone of the bladder will come to normal slowly. Explain the procedures to the patient or the attendant. Tell him that they may be a straight pain Put the sterile gloves on and fully deflate the balloon using a 20 cc syringe. And once you have fully deflated the balloon, put the catheter out gently. Discard the catheter and the urine bag. Now, moving to the next topic, it is a type of the contraceptives. The different types of the contraceptive includes the caps, the combined pills, the condoms, contraceptive implants, the contraceptive injections, contraceptive patch, diaphragm, female condoms, female sterilization, which is permanent method known as BTL, and IUD, intrauterine device, coil, IUS, intrauterine system, and the progesterone only pill, mini pill, vaginal ring, and the vasectomy, permanent method, and the natural family planning, and the fertility awareness. Contraceptive. The most important topic is the contraceptives in the breast cancer patients. Which contraceptives they can be used in the patients with the breast cancer? It is the barrier method, condom or the cap, which is the best. The barrier method they usually use with the lubricating jelly if you need extra moisture during the sex. A coil IUD, that is a small T-shaped device that a doctor or the nurse they puts it into you. It does not release a hormone and can stay for 5 to 10 years. Sterilization, the some women they use this to stop the risk of the getting pregnant if they are but they don't want children in the future. Next is the marina. What is Mirena, its composition, and for how long it provides the contraception? Mirena, it is a hormonal intrauterine device or the IUD that can be used for the long-term birth control and to treat the heavy periods. Mirena IUD, they works to prevent the pregnancy by the thickening the mucus in the cervix, which stops the sperm for fertilizing an egg, and the thinning the lining of the uterus, which suppresses the menstrual bleeding. The Mirena, the birth control, they works by the releasing the levonorgestrel. These hormones they thins the lining of the uterus, and it also thickens the mucus in the cervix. As a result, the sperm has a hard time moving and surviving in the uterus. This prevent the pregnancy. The thinning of the uterus, the lining, they can also reduce or stop the menstrual bleeding. Mirena they last for up to the 5 years, and according to 2017 Mirena prescribing information. The potential complications of the Mirena include ectopic pregnancies and the perforation of the uterus wall or the cervix, and the Mirena they may also cause the severe infections including the pelvic inflammatory disease and the sepsis. Now moving to the next topic, which is the fallopian tube. What are the parts of the fallopian tubes? The fallopian tube is described as having the four parts. Number one is the fimbria, finger like slated projections which capture the ovum from the surface of the ovary. Infundibulum, the funnel shape opening near the ovary to which the fimbria are attached, and the ampulla, the wider sections of the uterine tube. Fertilization usually occur here. And the isthmus, it is the nervous section of the uterine tubes connecting the ampulla and the uterine cavity. Management of the eclampsia, it is also another important topic which is usually asked in the exam. The eclampsia, it is a severe form of the preeclampsia. Women with eclampsia, they have the seizures resulting from the condition. Eclampsia they occurs in about 1 in 1600 pregnancies and develop near the end of the pregnancy in the most cases. There are five main principles to address in the management of the eclampsia, each of which are discussed in and here. Number one is the resuscitation, A, B, C, D, E assessment and the intervention as appropriate. The patient they should lie in the left lateral position with the secure airways and oxygen therapy. Second is the cessation of the seizures. Eclamptic seizures are treated with a magnesium sulfate MgSO4. The patient they should be assessed for the signs of the hypermagnesium, which is a hyperreflexia, respiratory depression, and the fetus monitored by the continuous CTG. Management of the eclamptic seizures with the magnesium sulfate. The prophylaxis includes a 4 gram in the 100 ml of 0.9% normal saline. The first seizure is 4 gram in the 100 ml of 0.9 normal saline, and maintenance dose is 1 gram early for 24 hours, and recurrent seizures includes the 2 gram bolus. The magnesium sulfate should be continued for the 24 hours after the delivery of the last seizure, which is described. The blood pressure control. The two most commonly used intravenous antihypertensive are the labetalol and the hydralazine. Um, Target mean arterial blood pressure is less than 120 millimeter of the mercury is used. A rapid decrease in the maternal blood pressure they can cause the fetal heart rate abnormalities, and therefore the continuous CTG monitoring is usually used during the first 30 minutes after giving the IV antihypertensive. Prompt delivery of the baby and the placenta. The only definitive treatment of the eclampsia is the delivery of the fetus. However, the mother they must be stable after before the delivery with anesthesia controls and the severe hypertension treatment and the hypoxia corrected. This is a case regardless of any fetal compromise. The cesarean session is the ideal mode of the delivery. However, the intrapartum phase is established and labor may be managed by the vaginal delivery. After the delivery, the patient will require HDU care still until she is stable with well-controlled blood pressure and adequate urine output and the discontinuation of the MGSO4. This usually takes a minimum of the 24 hours. And the monitoring balance monitoring is important to prevent the pulmonary edema and detect the acute kidney injury. The indication of the complication of the eclampsia should be monitored, such as the platelets, transaminases, and the creatinine levels for the HELLP syndrome. Next is the Colles fracture. It is a very common fracture in the children, so it is also very. A Colles fracture is a complete fracture of the radius bone and the forearm close to the wrist, resulting in an upper posterior displacement of the radius and obvious deformity. It is commonly called a broken wrist in spite of the fact that the distal radius is the location of the fracture, not the carpal bones of the wrist. The fracture they originate from a fall on the outstretched hands and is usually associated with the dorsal and the radial displacements of the distal fragments and the disturbance of the radial ulnar articulation. Possibly the ulnar styloid they may be fractured. Communications of the distal fragment and the fractures into a joint surface is present in some of the fractures. The Colles fracture is one of the most common and the challenging outpatient fracture. Colles fracture is defined as a linear transverse fracture of the distal radius approximately 20 to 35 mm proximal to the articular surface with the dorsal angulations of the distal fragment. The below is a picture of the Colles fractures. Now the next topic is ILR, which is the Iceland refrigerator. ILR or the Iceland refrigerator, they are used for the vaccination storage in the health facilities. They usually ask the questions about the storage temperature. What will you do if the electric supply of the BHURC or the health facility is disconnected for 24 hours? This type of the refrigerator is especially designed for the vaccine storage and indeed is different from a normal top opening refrigerator. It can keep the vaccine safe with as little as 8 hours electricity supply in a 24-hour period and come in the various sizes for the use at the different levels in the cold chain. The design is the top opening, and because this type holds the cold air inside better than a refrigerator with a front opening door. Inside the refrigerator, a lining of the water contains ice packs or the tubes. They are fitted around the walls and the opening is placed by the frame, which while the refrigerator is operating the water in the container before frozen, and if the electricity supply fails, the lining of the ice keeps the inside temperature of the refrigerator at a safe level for the vaccination for a very long time, usually for at least 2 days, provided the door is not opened frequently. This type of refrigerator have the heavy duty compressors which will start at the low voltages and continue to operate even if there are the large variations in the supply voltage. Points for the installations and the use of the Iceland refrigerators. Install the lining of the water containing completely according to the manufacturer instructions, and after adjusting the thermostat, allow at least 24 hours for the temperature inside the change. This stays longer than a household refrigerator being because of the ice lining. Put the BCG, mumps, and the polio and the measles vaccines, if not kept in a separate freezer. And the bottom where it is closest. Put OPVTT and the hepatitis or the pentavalent vaccines in the baskets near to the top. Do not put these vaccinations within the 15 centimeter of the bottom of the compartment to avoid the risk of the accidental freezing. In the winter or the whenever the room temperature drops below the plus 10 degrees centigrade, pay close attention to the temperature checking, thermostat adjustments, and the conditions of the absorbed vaccines. In these conditions, the refrigerator they may easily get too cold inside, even with the thermostat at its warmer setting. The summary points: at the regional level, keep the vaccines for the maximum of the 3 months, and the store OPV, measles, mumps vaccines in the freezer at the minus 10, 15 to minus 25 degrees centigrade, and store TTB, BCG, hepatitis B, and the pentavalent vaccines in the refrigerator, preferably ice lined at the 0 to plus 8 degrees centigrade. Pay special attention to the temperature checking in the very cold weather. Now, next most important topic is the rule of nine, or the burn. A burn is a type of the injury to the skin or the other tissues caused by the heat, cold, electricity, chemical frictions, or the radiations. Most burns are due to the heat from the hot liquids, solids, or the fires. The types of the burn, they are the superficial first degree burns, and the superficial partial thickening second degree, the deep partial thickening second degree, and the full thickening third degree, and the fourth degree burn. The superficial, the first degree, but the layers involves the epidermis. The appearance is the red without the blisters, and the texture is dry, and the sensation is painful, and the healing time is 5 to 10 days, and the prognosis the heals well, and repeated sunburn increases the risk of the skin cancer later in the life. The second is the superficial partial thickness, the second degree burns. The layer involved is extended into the superficial papillary dermis, and the appearance is redness with the clear blisters and the branches with the pressures, and the texture is moist and sensation very painful, and the healing time is 2 to 3 weeks, and the prognosis the local infection cellulitis, but not no scarring typically. The third is the deep partial thickening. The second degree burns. The layers involves extended into the deep reticular dermis, and the appearance is yellow, the white less blanching, and the maybe blistering, and the texture is fairly dry, and sensation is the pressures and discomfort. And healing time is 3 to 8 weeks, and the prognosis is scarring contractures. Uh, the full thickness burn, it includes the layers involves extended through the entire dermis, and the appearance stiff and the white brown, no blatching, and the texture is the leathery, and sensation is painless, and the healing time prolonged months, and the incomplete. Prognosis, scarring, contractions, and the amputations, early excision recommended. The fourth degree, the layers involves are extended through the entire skin and into the underlying fat, muscles, and the bone. Appearance is a black charred with the skin, and texture is a dry, and the sensation is painless, and the healing time requires the excisions, and the prognosis amputation, significant functional impairment, and in some cases the death. The size of the burn. The size of the burn is measured as a percentage of the total body surface area affected by the partial thickness of or the full thickness of the burns. The first degree burns that are only red in the color and are not blistering and are not including in the estimations. The most burn, 70%, involves less than 10% of the TBSA. There are the number of the methods of the to determine the TBSA, which is the total body surface area, including the Wallace rule of the ninth, the Lund and the Bruder chart, and the estimation based on the person's palm size. The rule of the nine is easily to remember, but only accurate is above over the 16 years of the age. The most accurate estimation they can be the made using the Lone and the Bruder chart, which takes in account the different portions of the body parts in the adults and the children. The body parts and the adults and the children. Entire head and neck, 9% will be included in the adults, and 18% will be included in the children. The entire left arm, the 9% in adults as well as in the children. The entire right arm, including the hand, 9%, 9%, both cases. Entire chest, 9% and 9%, and entire abdomen, 9 and 9, and entire back, 18 and 18, and groin, 1 and 1, and entire leg, including the feet, 18, and in the children it is considered 13.5, and entire right leg, 18%, and in the case of the children, 13.5%. The trunk, chest, abdomen, and the back, they consisting of the total of the 36%. So it is a pictorial view. The head and neck, 9%, the upper limbs 9% each, and the trunk 36%, and the genitalias 1%, and lower limbs the 18%. Now, what is the hospital admission criteria in the children? If it is more than or equal to 10% burn, in adults more than equal to 15%, the patients with the burn involving the whole circumference of the limb, the compartment syndrome is possible, hence it's a necessity for the admission. The investigations, complete blood pressure, FFTs, RFTs, and the serum electrolytes. The most important, the blood sugar levels and the ECG are important. The management, the resuscitation begins with the assessment and the stabilization of the person's airway and the breathing and the circulations, and the painkiller, for example, injection, tramadol, they can be given. A tetanus booster, they should be considered if an individual has not been immunized with the in the last 5 years. The important intravenous catheter, they may be placed through the burn skin if they're needed, or the intraceous infusions they may be used. Intravenous antibiotic for those with the extensive burn of more than 60%, and if the inhalation injury is suspected, early intubation they may be required. Intravenous fluids includes in the children with more than 10 to 20% TBSA burns, and the adults with the more than 15% TBSA burns, the formal fluid resuscitation and the monitoring they should be done. The Parkland formula, they can help determine the volume of the intravenous fluid required over the first 24 hours. The formula is based on the affecting individual TBSA, and the weight formula is equal to weight into percentage of the burn, and multiply by 4. The half of the fluid is administered over the first 8 hours, and the remainder they over the following 16 hours. The time is calculated from where the burn they occurred, and not from the time the fluid resuscitation begins. The children requires additional maintenance fluid that includes the glucose, and additionally those with the inhalation injuries they requires the more fluids. And the inadequate fluid resuscitation they may be cause the problems. Over the resuscitation they can be determined. The formula they are only a guide, with the infusion ideally tailored to the urinary output of more than 30% 30 ml per hour in the adults, and 1 ml per kg in the children, and mean arterial pressure greater than the 60 millimeter of the mercury. The fluids includes lactated ringer solutions is often used. Now, how to care the wound? The early cooling within say 30 minutes of the burn reduces the burn depth and the pain, but the care they must be taken, as the overcooling they may result in the hypothermia. It could be performed with the cool water 10 to 25 degree, and not the ice water, as the later they can cause a further injury. The chemical burns they may require the extensive irrigations and the cleaning with the normal saline, and removal of the dead skins, and the applications of the dressings. They are important aspects of the wound care. If the intact blisters are present, the some tentative evidences they should be suppose leaving this intact. In the management of the first and the second degree burns, the little quality the evidences they exist to determine which dressing the type to be used. It is reasonable to manage the first degree burns without the dressing, and while the topical antibiotics they are often recommended, there is the little evidence to support that they use, such as the silver sulfazide and the dermazine or the quench is not recommended, as it potentially prolongs the healing time. There is insufficient evidence to support the use of the dressing containing the silver. The complications: the infections of the wounds, the sepsis, hypovolemic shock, the acute gastrointestinal curling ulcer, and the post-burn seizures in the children, and aspiration, the unconscious patients are causing the bacterial pneumonia and the pulmonary edema. Now moving to the next topic, it is the esophagus. The esophagus is a muscular tube about the 10 inches 25 centimeter long, extended from the hypopharynx to the stomach. The esophagus they lies posterior to the trachea and the heart, and passes through the mediastinum with and the hiatus, and opening in the diaphragm. It in its descent form of the thoracic or to the abdominal cavity. The esophagus has no scirrhosal layer. Tissue around the esophagus is called the adventitia. The length of the esophagus at the birth varies 8 to 10 centimeter and measures about 19 centimeter at the age of the 15 years. There are the two subsite descriptions for the esophagus, as they are not equivalent. The subsite description one, the cervical being at the begins at the lower end of the pharynx, and the level of the sixth vertebrae or the lower border of the cricoid cartilage, and extends to the thoracic inlet, the suprasternal notch 18 centimeter from the incisors. Number second is the thoracic. Upper thoracic, they from the thoracic inlet to the level of the tracheal bifurcation 18 to 23 centimeter, and the mid thoracic from the tracheal bifurcation midway to the gastroesophageal junction 24 to 32 centimeter, and the lower thoracic from the midway between the tracheal bifurcation and the gastroesophageal junction to GE junctions, including the abdominal esophagus 32 to 40 centimeter. Abdominal, the considered a part of the lower thoracic esophagus 30 to 40 centimeter. The subside description: 2, the upper third 10% of the esophageal cancers, and the middle 40%, and the lower third is the 50% of the cancers. And next most important topic is the asthma. The brief statistics includes the According to the available global estimates, around the 300 million people they currently suffer from the asthma, which has become more common in the adults in the recent decades. One in every 250 deaths they worldwide they have been attributed to the asthma, which was found to rank the 26th among the causes associated with the years of the life lost in the South Asia. The increase in the prevalence of the asthma they has been associated with an increase in the atopic sensations, and in the parallel by the similar increase in the other allergic disorders such as the eczema and the rhinitis. The rate of the asthma they increases as the communities they become more urbanized, with the projected increase in the portions of the world population. This is the urban from the 45 to 59% in the 2025. That is likely to be marked increase in the number of the asthmatic worldwide. According to the Indian's National Family Health Survey, the prevalence of the adult self-report asthma there was around 1.8%. Asthma the prevalence there has been found to vary from the zero point 0.7 to 11.9% across Asia, but the definition they used to identify the asthma they also varied extensively. The report on the global burden of the asthma estimated the prevalence of the asthma in Pakistan is to be 4.3%. The following organizations they have issued the guidelines for the management of the asthma: the National Asthma Education and the Prevalent Programs, and the Veterans Administration Department of the Defense, and the Global Initiative for the Asthma, GINA mostly used, and the Japanese Society of the Allergology JSA. The most important is the status the asthmaticus, and it is an acute exacerbation of the asthma that remains unresponsive to initial treatment with the bronchodilators, and the clinical feature cough, shortness of the breath, and the wheezing, and the investigation FEV1 and the methacholine challenge test, and the CBC and chest X-ray. Management includes the oxygen inhalation, the Ventolin nebulization 0.1 to 0.5 milligram per kg per dose, and repeat after the 20 to 30 minutes 1 cc Ventolin and 1.5 ml normal saline. Atom apratropium nebulization into TDS, and the clinal nebulization 1 ampule into TDS, and the infusion the Plabulite M25 ml per kg IV TDS, and the injection oxidil ceftriaxone 50 mg 50 to 100 mg per kg IV OD. Injection augmentin amoxicillin plus the clavulanic acid 20 to 50 milligram per kg per day in the 3 divided doses. Injection isonate hydrocortisone 10 mg per kg IV endostat, and then 5 mg per kg IV TDS, and the injection aminophylline 6 mg per kg per dose IV stat, then 2 to 4 mg per kg per dose BD in the fluid. When the acute attack is over, put the patient on the oral medication such as tablet, syrup, Ventolin, and the Montelukast sachet. Next is the cholelithiasis, another important problem in Pakistan. The gallstone diseases they may be thought of the having the following four stages: the lithogenic state, in which the conditions favors the gallstone formation; asymptomatic gallstone, then the symptomatic gallstones are characterized with episodes of the biliary colic, and the complicated cholelithiasis. The symptoms and the complications of the gallstone diseases they result from the effect occurring within the gallstones or from the stones that escape the gall bladder to launch the common biliary duct. And the biliary cirrhosis the pain they term biliary colic they occurs when the gallstones or the sludge they fortuitously impact in the cystic duct during the gallbladder contractions and increasing the gallbladder wall tension. In the most cases the pain they revolves over 30 to 90 minutes as the gallbladder they relaxes and the obstruction is relieved. The common symptoms of the cholelithiasis: abdominal pain, abdominal swelling, distensions of the blotting, abdominal tenderness, and the clay stool colored stools, and the fever and the chills, the loss of appetite, the nausea, and the with or without the vomiting, and the pain that radiates from the abdomen to the right shoulder or the back, and the sweating and the yellowing of the skin and the whites of the eyes, jaundice. In some cases, the cholelithiasis they can be life-threatening with the following: abdominal swelling, distension, the blotting, high fever, the higher than 101 degree Fahrenheit, nausea with or without vomiting, and the severe abdominal pain. What are the risk factors for the cholelithiasis? A number of the factors increases the risk of the developing cholelithiasis. Not all people with the risk factors they will get the cholelithiasis. The risk factors for the cholelithiasis includes the age over the 40 years and the crash dieting or the losing weight rapidly, diabetes, ethnicity, more in the American Indians and the Mexican Americans, and the family history, family, gender, liver diseases, overweight or the obesity, and the pregnancy decreases the gallbladder ability to empty the bile, and the use of the certain medications. The reducing your risk of the cholelithiasis, although the some risk factors such as the age and the gender they cannot be modified, you may be able to lower your risk of the cholelithiasis through the lifestyle changes, including eating a healthy diet and the getting regular physical activity and the losing the weight slowly and the maintaining a healthy weight. The temperature, the treatment options for the cholelithiasis includes the treatment of the cholelithiasis that begins with the seeking the medical care from the healthcare provider, and to determine if you have the cholelithiasis your health they can care provider they may ask you to provide the blood samples and undergo the diagnostic test. And the some people with the cholelithiasis they never have any symptoms. If you have the symptoms of the cholelithiasis, you may be hospitalized and given the antibiotics to prevent an infection. Food intake is normally stopped, and the intravenous fluids are administered to the let the digestive system rest. And you may also receive the medications for the abdominal pain associated with the cholelithiasis. If you have recurrent episodes of the cholelithiasis, the most common treatment is the surgery to remove the gallbladders, and there are the two methods of this surgery: the open cholecystectomy, and when the whole organ is removed through the single incisions, and the laparoscopic cholecystectomy, where the gallbladder is removed into the pieces through the several small incisions. The laparoscopic technique is now used more frequently, and because the gallbladder is not an essential organ, most people who have the cholecystectomy they can live in the normal life afterward. The several treatment options they are now available for the cholelithiasis. Laparoscopic cholecystectomy is currently the most frequent used techniques. Options includes the endoscopic retrograde cholangiopancreatography, RCP, and imaging procedure that allows the treatment of the some bile duct problems involved in including the removal of the gall stones that are causing the obstructions. Laparoscopic cholecystectomy, the removal of the gallbladder through the multiple small incisions, and there is the less invasive. Lithotripsy, the technique that use electrical shock waves to dissolve the gallstones, that is not common use today. The medication to dissolve the gallstones uh, includes this treatment that takes a longer time. The gallstones may recur. Open cholecystectomy, removal of the gallstones that through a single large incision. Is a more invasive and the less commonly used technique. What are the potential complications of the cholelithiasis? Cholelithiasis may cause the serious complication of the gallstone lodged in the common bile duct, which is a large duct formed where the major gallbladder, the bile ducts, they joins the major liver bile ducts. You can help them minimize your risk of the serious complications by following the treatment plan that you and your healthcare professional they design specifically for you. Complication of the lithiasis includes the acute cholelithiasis, the sudden inflammation of the gallstones, the cholangitis, and infections of the inflammations of the common bile ducts, and the cholelithiasis, the gallstones, and the common bile duct, and the pancreatitis infections, infection of the pancreas. The cholelithiasis is the microscopic crystal of the large stones in the gallbladder, and the cholecystitis, inflammations of the gallbladder, and the choledocholithiasis, the common bile stone, duct stones, and the biliary dyskinesia, the motility disorders of the gallbladders are caused by the scarring or the spasm of the sphincter of the Oddi, and the gallbladder perforations and the are normal. A hole or the opening in the wall of the gallbladder, acute generalized biliary peritonitis, and the subacute acute plus a polycystic abscess, and the chronic is the cholecysto-indirect fistula. And the gallstone pancreatitis, the inflammations of the pancreas, they caused by the obstructions of the pancreas ducts by the gall, and the gallbladder. Diagnosis of the gallbladder disease. The current technique for the diagnosis of gallbladder disease, they are the less invasive and allow the patient to recover more quickly than was the in case with either the diagnostic procedure. Although the incidence of the cholelithiasis is quite high in the US, few patients they presents with the symptoms, and this can complicate and prolong the diagnosis. CBC liver function test and the serum myelitis and the lipases they should be included in the laboratory test to help the discriminate between the various types of the gallstones disease and identify the complications caused by the gallstone disease. The diagnosis of the cholelithiasis, cholecystitis, and the other gallstone diseases, they can be confirmed by a number of the different imaging techniques. Ultrasonography and the colonscintigraphy are the imaging studies the most commonly used to diagnose the cholelithiasis and the cholecystitis. Positive finding they upon the ultrasonography includes the stones, the thickening of the gallbladder wall, and the pericocystic fluid, and the Murphy sign suggest the pain upon the contact with the ultrasonography probe. The ultrasonography performed is the fasting state reveals the correct diagnosis in more than 90% of the cases, but the bile duct stones they may miss the 50% of the cases. Cholecystography, they also has a hepatobiliary immunodidactic acid scan is used to assess the functions of the gallbladder and the diagnose acute the cholecystitis. HIDA scan, they are all not helpful in the identifying the cholelithiasis or the chronic cholecystitis. And now moving to the Courvoisier's law. It states that the painless, palpably enlarged gallbladder, they are accompanied with the mild jaundice, is unlikely to be the caused by the gallstone, because the stones they would have given the rise to the chronic inflammation and the subsequent fibrosis of the gallbladder, and therefore the rendering it incapable of the inflammation. Usually the term is used to describe the physical examination finding of the right upper quadrant of the abdomen. The sign implicates a possible malignancy of the gallbladder, pancreas, and the swelling is like unlikely due to the gallstones. The Murphy signs is a maneuver which is during a physical examination as a part of the abdominal examination. It is useful for the differentiating pain in the upper right quadrant, and typically it is possible in the cholangitis, but the negative in the cholelithiasis, pyelonephritis, and ascending cholangitis. The Murphy sign is tested for the during an abdominal examination in a supine position. It is performed by asking the patient to breathe out and then gently placing the hand below the costal margin, the right side of the mid clavicular line, and the patient is then entrusted to breathe in normally. That during the inspiration the bladder to the contents are the pushed down, and the diaphragm moves down and the lungs expands. If the patient they stops breathing the in the as the gallstone is tender and is moving downwards, comes in contact with the examiner's fingers, and the wins is the catch in the breath, and the test is considered positive. If in order for the to consider positive the same maneuver, they must elicit the pain which performs on the left side. Murphy's triad is a collection of the three signs and the symptoms associated with the acute appendicitis, a medical emergency that presents with the lower right abdominal pain, right lower quadrant pain, and along with the nausea, vomiting, and the fever. Components of the Murphy triads includes the pain, vomiting, and fever. Mnemonic is the PBT Murphy, the pain, vomiting, and temperature. And now the last topic of this video is the nephrotic syndrome. The nephrotic syndrome is defined to be a triad of the clinical features: edema, substantial proteinuria 3.5 gram per 24 hour, and the hypoalbuminemia, which is less than 30 gram per liter. It is often associated with the hyperlipidemia, the thromboembolism, and is and an increased risk of the infections. Nephrotic syndrome that develops following the pathological injury of the renal glomeruli. This may be primary problems, and with the disease specific, the kidney or the secondary to systemic disorders such as the diabetes mellitus. The most common cause in the children is a minimal change glomerulonephritis. In the white adult, nephrotic syndrome is the most frequently due to the membranous nephropathy, whereas in the population of the African ancestry, the most common cause of the nephrotic syndrome is the focal segment glomerulosclerosis. The diabetic nephropathy is the most common multi-system disease that can cause the nephrotic syndrome. The patients they typically usually presents with the periorbital edema, most noticeably in the morning, dependent pitting edema, proteinuria, and proteinuria. They should be documented quantitative measurement, for example, the urine protein and creatinine ratio, PCR, or the albumin, and ACR. PCR is more than 300 to 350 milligram per millimole, indicates an nephrotic range proteinuria. Urgent referral to a nephrologist ideally within the 2 weeks is necessary, and the renal biopsies are usually performed, and this is established that what form of the glomerular disease is responsible, and additional tests they may be undertaken to assess if the nephrotic syndrome is secondary to the another disorder, for example, systemic lupus erythematosus or the amyloidosis. The nephrotic syndrome is usually accompanied by the retention of the water and the sodium. The degree to which this occurs, they can vary. The slight edema in the eyelids that decreases during the day, affecting the lower limbs, to the general swelling to the full brown and anasarca. Related to the nephrotic syndrome, the nephritic syndrome is the syndrome comprising the sign of the nephritis, which is a kidney disease involving the inflammation. It often occurs in the glomerulus, and where it is called the glomerulonephritis. The glomerulonephritis is characterized by the inflammation and the thinning of the glomerular basement membrane, and the occurrence of the small pores in the podocytes of the glomerulus. These pores they become the large enough to permit both the proteins and the red blood cells to pass into the urine. And by contrast, the nephrotic syndrome is characterized by the proteinuria and constellations of the other symptoms that specifically do not include the hematuria. Nephritic syndrome, like the nephrotic syndrome, they may involve the low level of the albumin in the blood due to the protein albumin and moving from the blood to the urine. The difference between the nephrotic and the nephritic syndromes that includes the typical features onset is insidious and the abrupt in the nephritic. Edema is highly positive in the nephrotic, whereas less positive in the nephritic. Blood pressure is normal in nephrotic and the raised in the nephritic. Angular venous pressure is normal, low in the nephrotic and the raised in the nephritic. And the proteinuria is highly positive in nephrotic and low positive in the nephritic. Hematuria may or may not occur in the nephrotic, whereas it is always present in the nephritic syndrome. Red blood cell counts are absent in the nephrotic and present in the nephritic syndrome, and serum albumin is low and normal slightly reduced. So this is it for today. Hope you like the video. It is to be continued video. This is part 3 of the video. Thank you. Take care. Till the next time. Bye bye.